Hyperemesis gravidarum is defined as a condition where there is excessive vomiting which is deleterious to the health of both mother and fetus. So basically there are a set of parameters based on which you say it is hyperemesis gravidarum. There has to be more than 5% loss of weight in the women. Then she has dehydration and she has electrolyte imbalance in the form of metabolic alkalosis because of loss of hydrochloric acid during vomiting. So what investigations will we undertake? We check for liver function test, which will be altered. Here she'll basically have jaundice. Then we do serum electrolyte levels. Then we check for serum T3, T4 because it is more commonly seen in women with thyroid dysfunctions. And ophthalmological examination where we see the retinal hemorrhages, EC which show abnormal changes because of abnormal potassium levels, hypokalemia basically. Then urine analysis, there is small dark colored urine. So the quantity is small because of vomiting, dehydration, reduced blood supply. And it has very high specific, it's very concentrated urine. Basically dehydration, what kind of urine we have? We have concentrated urine, right? So the quantity is less. It is dark in color. It has very high specific gravity. It can have a lot of protein, acetone and other pigments. And there is less amount of chloride because all the chloride was lost in vomitus. So these are the investigations that we'll undertake. Now there are a set of complications which are seen here. So there are complications on the mother and complications on the fetus. In the fetus, basically fetus won't have a lot of complications. They can just be low birth weight, IUGR, preterm labor. But in the mother, there will be a lot of complications. So because of repeated vomiting, there can be stress ulcers, there can be malarial tear in the esophagus, then jaundice, convulsions and coma because of dehydration, loss of blood supply, hypoprothrombinemia due to vitamin K deficiency because it is lost, then renal failure, and they can have neurological complications in the form of peripheral neuritis, Korsakoff psychosis, Wernicke's encephalopathy, beriberi, and pontine myelinolysis. So how will we manage this patient? Firstly, we have to maintain good hydration. Basically, we want to stop vomiting, we want to maintain good hydration, maintain good serum electrolyte balance, and if there is any metabolic alkalosis, then we want to tackle that, and we want to take care of all the vitamin deficiencies, and basically take care of the pregnancy and make sure that the pregnancy prolongs for a long time. So generally our management involves hospitalization. Generally we hospitalize, and here since she's vomiting and not in a state to take oral fluid, we stop oral fluids for 24 hours. And at least for 24 hours, even after vomiting, we have to stop oral fluids completely. Till that time we start giving them IV fluids, mainly normal saline, ringalactate, dextrose can be given. So initially crystalloids are given, later if needed colloids are added, usually not given. And basically almost 3 liters, dehydration is so bad that almost 3 liters of water has to be 3 liters has to be transfused. So first we'll give it in first 24 hours IV bolus and later IV infusion, and we try to maintain all the fluid electrolyte balance. And we can give drugs. So there is vomiting, we have to go for anti-emetic drugs. So we give drugs like prochlorpromazine, promethazine, metoclopramide. We also add doxylamine, vitamin B6, and hydrocortisone might be given for hypotension in case of intractable vomiting. Ondansetron is a second line therapy, and vitamin B1, B6, B12 and vitamin C supplementation. So mainly antiemetics like prochlorpromazine, ondansetron, doxylamine, these are given. Hydrocortisone is given just to improve hypotension. Then nursing care like parenteral thiamine can be given to and then you have to prevent complications like Wernicke's encephalopathy, beriberi. Then for stress ulcers, we can give proton pump inhibitors, and if because of dehydration, in case there is hemoconcentration, then we give prophylaxis with low molecular weight heparin. So and then we have to make a hyperemesis progress chart wherein daily we record pulse, temperature, BP at least twice a day. Then urine output is checked. Urine is checked for acetone, proteins, bile, etc. And clinical features of improvement are vomiting, reduction of vomiting, then improving urine output becomes better, jaundice resolves, appetite is there is increase in appetite, the disappearance of acetone from breath and urine, normal pulse and BP, normal growth of fetus. After this, oral diet can be started. So since we had stopped oral diet for a period of time, you can't immediately start giving a lot of oral food. We begin with the basics, wherein we are giving her a little amount of carbohydrates like biscuits, bread, toast, and gradually diet is built. Termination of pregnancy, if is done when vomiting is intractable these days with better medication and interventions. Termination of pregnancy is a rare phenomenon in case of hyperemesis gravidarum.